So I'm really pleased to be able to welcome her to lead this event today. Afsana and many of us all work for the North Central London Cancer Alliance, and we've got lots of colleagues from the East as well, and from our local academic institutions helping us today. We've just put a little slide up just to say who are we, and you'll be able to have a look at that later. We're recording it, and so you'll be able to see that later on. But essentially, we're one of the 21 cancer alliances in England, and we're focused on early diagnosis, treatment, developing pathways to treatment, supporting best practice and reducing variation. So thanks very much for all of you attending today, and I'll hand over to Afsana.
Thank you, Claire, for that lovely introduction. So let's crack on. Should we get my slides up? So really today is, I can't see the slides, but Catherine, I'm hoping like magic they will appear. Today we are really bringing to you an audience that I think will be familiar already with the e-safety netting toolkit that's within EMIS Web, and it's really about updates addressing a lot of queries that had come to us over the last year, and then really hoping to bring some kind of really key stories about adopting, adapting, and then the vision for next steps. So if we move to the next slide, and why don't we have a look at what we've got lined up for you. So I'll just be introducing the kind of the narrative, the history to how we got here, and then show you those key updates and address some of those questions that I've compiled. Then we'll have that panel discussion with our colleagues that you can see here, and I'm going to let them all introduce themselves, and then we'll talk to you about kind of our reflections and appraisals on other safety netting toolkits out there, and finally what are those next steps. And just to clarify, so this webinar is not about how you implement e-safety netting. We've done that, there are lots of recordings of that, so if you do wish to do that, this is not the talk for you. Okay, next slide. Thank you. So on the next slide you'll be able to see who we've got lined up to speak, and I can't see them.
One moment, Afsana, it's not moved on for some reason.
Oh, that's okay, no problem.
Just a minute. I'm going to reload them. I don't know why it's stuck.
Okay, so I think why don't we come back to kind of showing people the names of who we've got on, and why don't I just remind people about the timeline of how we got here, and then we can bring that slide up as it appears. Oh, brilliant. Okay, so these are who we have today, and as I said, everyone's going to introduce themselves. So why don't we move on and have a look at the timelines. Now, I always find this is helpful because it really shows you if you have an innovation or a service change or a service provision in the NHS, I suppose the time, the commitment, the things that you need to do to drive through that change. And for me, this slide really captures that for this particular project. So really, my time started with the cancer world in 2015, and that's really where all the kind of the drivers for policy change around NG12 and the Cancer Task Force report came out that propelled the work around improving coding, around safety netting. And then this led to a development of a module in collaboration with Macmillan, and then for me in 2017, that innovation stage about what does e-safety netting look like in practical terms. So doing the processes that some people might be familiar with around prototyping and testing, and then demonstrating. And remember, you know, like some things within the NHS, when you're trying to invoke change, can be done through different ways, through commissioning or none. And this has always been something that's really been led by grassroots GP, kind of seeing that motivation for change. And so then really propelling into 2018 and doing the spread challenge around dissemination and scaling up and refining that tool. And then in June 2018, we were able to get the Safe Netting Toolkit as a national toolkit with Macmillan's support and advocacy. And that was then much easier to disseminate and for users to use. And so then after that came various other stems with these projects they do. We have a research arm that started in 2019. 2020 was obviously a significant year for all of us in terms of the impact of COVID-19. And really for us, we saw that real mandate for robust safety netting for our patients. And then this year really has been around supporting the wider spread of this project. There have been sort of more national levers for using this, so people are familiar with the PCN DES for early diagnosis. We've published case studies with NHSX, and then we're going to talk a little bit more about some case studies that we published, as we've got our GPs involved in that case study document here today. So if we can we move on to the next slide? Thank you. And then this slide is just showing you the hyperlinks for where you can get more information and all of these things that I've talked about. So this slide is really just to remind people that, yes, this is a national toolkit, so it sits in EMIS Web and anyone can access it. Also importantly, that this is a whole practice team and systematic way of working. So it's not about one person using it or one administrator using it. This really takes a big change in the way a practice runs. And we now have the template with 5 pages. So the additional page is really to capture screening. And then how it works really is around coded events in the templates, which are tagged to diary entries that are linked to these timed reminders. Those reminders will appear on the searches, and as part of that, we have these alerts that pop up when a patient record is accessed. OK, so let's get into the meaty bit, which is really what are those updates and addressing some of those questions. So what we haven't done here is we haven't changed any of the core functionalities. So all the implementation remains the same and how you operate the system in your practice is the same. The updates were in place as of the 15th of November, so very recently. And in those changes, there were some visual changes, some things to do with titles that people were not familiar with. We've tweaked the searches and the template pages. Importantly, we've added in that cancer safety net SNOMED code that everyone's been asking me about, and this is important obviously because of that PCN DES dashboard that NHS England require practices to evidence that they are using cancer safety netting. So you know, that's there. We've got lots of refinement in the counselling aspects of the text that's been updated, and we've addressed some issues with the transition between READ coding to SNOMED coding. So some people might have seen or been aware of glitches that had occurred when the two when EMIS Web moved to SNOMED, and as a result there were issues with the searches, issues with coding, and I've been reassured now through the process that I've undertaken in the EMIS Web that these things have now been addressed. Importantly, the SMEA due code has been removed because I know lots of practices were getting lots of entries around that, so that's hopefully a positive. OK, so should we take a look at what some of these changes look like? So what I've got for you over the coming slides are the screenshots of each of those pages, and then drill down into some of the detail of that. So this is page 1. This has always been about tracking your suspected cancer referrals, and at the top there you can see that SNOMED cancer safety netting code is now embedded. If we move on to the next slide, we can have a look at page 2 on that template, and this is about direct access investigations and test requests. Nothing over on this page, but again, it's more about enabling GPs, clinicians to record their counselling notes, actions, and advice, and making sure that those hyperlinks were all updated. OK, so should we go to the next slide? So this page has changed a little bit. This was always about patients with low risk but not no risk of having cancer. And what we've done here, based on feedback that we had when we were sort of initiating work around this, was around making it easier and more explicit around vague symptoms. So rather than having dropped down the coding of vague symptoms are now on the page, and it enables you to put text around it as well. So I think that's pretty much all about page 3, and that's quite small. So but essentially the first half, as people might remember, is all about the system pulling together cancer related results, and then the latter, the bottom part, has got improved coding on specific things. One thing I wanted to point out was that we've added a code for the injection of gonadotrophin releasing hormones. In NCL, it's obviously something that people do, particularly in the context of prostate cancer, so it's just to flag that up really. OK, should we move on to the next slide? The template name often caused confusion, and so really just to say that the template date, so it says it's called Safe Dating Template, and actually the date inside it reflects the year that it was updated. So I hope that that makes sense to everybody. Okay, and then moving on to the next slide. So this is obviously the back office view of somebody who's more IT au fait of what the triggers would look like. So triggers are codes within that template that would open up the template if a clinician or somebody was using the template without opening up, using a cancer related event but not opening up the template. So it opens up the template for them to then use all the facilities within the template. Should we move on to the next one? So this is this is basically page 4 again, but actually now you can see better. So this is a closer picture of what page 4 looks like. And I think, yeah, now people have had a chance to look at that. So page 5 is interesting because it's, yeah, sorry, Catherine, yeah, do keep it on page 5. So this is new, and there's always been a tension of kind of updating a product that is national versus what people sort of request locally. And I think we had to reach a point where you have to do something that enables it, but not so it doesn't become distracting, but also that the information that you're tracking can be sort of consistent for people to use across the country. And so really where I got to with this was kind of being able to allow people to kind of hold information about the 3 cancer screening programs, but more importantly, if they wanted to add a follow-up, so use this in the tracking system, do that through one code and then just specify the information that they want around it. So keeping it simple, not putting too much information in, but enabling the screening aspect really. So that is, yeah, so let's go on to the next slide. And just to show you, as people are probably aware, each of those pages have protocols behind them that enable the alerts to pop up. And because page 5 is new, this is what that alert will show if you track somebody on that page. OK, so that takes us to the end of kind of those updates, and I wasn't really expecting a kind of a barrage of questions there. It was more for information, and this bit actually is you know, the bit that I think will be really interesting. So I'm really pleased that we've got some great speakers here today to talk about adopt and adapt and just the context to this really. So again, just building on the point I talked about new innovations following these stages, and really we've done the ideation, we've done the development and the spreading, but then, you know, where you get to with a project in terms of how do you adopt it, how do you adapt it, how do you sustain it? And I think this conversation here will really talk to us about that. So we're going to hear from Rasha, we're going to hear from Tanya, we're going to hear from Jen and Anthony. So I'm going to actually, if you're all able to unmute yourselves, why don't you introduce yourselves, and then perhaps if we go through, if I call you out, and then just tell us your own, I suppose, adopt journey, and then I can drill into specific questions if that's okay. Yeah, so we've lost Anthony for a few minutes, but that's okay. Okay, so Rasha, why don't you go first? Tell us who you are.
Hi. Hi, everybody. Some familiar names on the screen as well. I'm Rasha Galarab. I'm a GP in North London. I work at the Free and Barnet Medical Centre. I've been here for about 8 years, having trained in Camden at the James Wade practice many years before that. And I have evolved my role here into a quality improvement lead at the surgery. And so I do quality improvement and training, and I've helped Asana do some of the safety net training throughout the pandemic virtually too.
Thank you. Tanya.
Hi, yes, I'm a GP in Bow in Tower Hamlets. I'm the cancer lead for Tower Hamlets Primary Care, and also have a role chairing the Tower Hamlets New and Waltham Forest Cancer Group as well. I think I've known Afsana for quite a long time, had a very few bees in my bonnet around cancer, would be fair to say, and have been cancer lead for about 8 or 9 years now in the area. So we have done various pieces of work that we'll have a chat about, which involves quality improvement work within the PCNs, within the primary care networks, because in Tower Hamlets we've had those around for over 10 years now. So I've had a robust vehicle to land things on, which has been very welcome before. So we did some quality improvement work around safety netting a few years ago with individual practices, which involved this tool, and more recently, as a PCN, been looking at how do we implement within a primary care network some quality improvement work. What are the challenges and kind of some of the opportunities as well. So that's why I'm here with you guys today, just to share some of that knowledge base.
And it's been such a pleasure working with you, Tanya. Jen, and then Anthony.
Hi everybody, so my name's Jennifer Ray and I'm a GP in North Islington, and since 2016 I've been working with the Islington Federation and then most recently with Islington PCNs, and I lead on the QI early cancer diagnosis work stream, and I have been helping support that over the last sort of 18 months within Islington.
And Anthony.
Hi everyone, I'm Anthony Cunliffe. I'm a GP in South London actually, and I work with Macmillan Cancer Support as one of their national clinical advisors. And I guess I've been working with Afsana on this tool for quite a while now. Certainly when Afsana first created it, and certainly I thought it was a fantastic product, and been really excited to see how it's been taken up. And through Macmillan, we worked with EMIS to support Afsana to get it onto EMIS nationally, because we all know, you know, to really have an impact, these tools, it's better if they're available to everyone across the country. So we worked to make that happen, which is great. And now it's all about promoting use of the tool. Certainly we use it in our practice, and it's a fantastic tool for all sorts of things really. So yeah.
That's really helpful to hear. So why don't we launch with Rasha? And Rasha, why don't you start with like telling us sort of why you adopted it, and then in terms of and I suppose one thing we have to be conscious of is time. So I suppose maybe 3-4 minutes each, just because then we can all hear our individual stories. But really, what motivated you? What were the challenges that you had? How did you get it flowing? And then I suppose really importantly, the sustainability of this in your practice.
Gosh, that's a lot to cover in a few minutes.
Yeah,
because I talk fast. I'm known for talking fast. There's a couple of reasons. First of all, patient safety initiatives are a real passion of mine. They've been for a really long time. They span not just across cancer safety, but also in terms of patients who seek, referrals into private sectors and so forth like that. So I've had a bit of a thing about patient safety for a long time. When I started to take on the lead role here at Free and Barnet, we're a 10,000 patient practice, part of quite a large PCN, and this safety net tracker came up as part of the UCL Alliance, and I was a UCL trainee, and this obviously came into my inbox, and I thought this is really, really important. There were very, very few tools that would enable our patients to be safe when, the pathway of patients, or what I call the patient UX, of how they go through a system, and all the gaps in the net where they fall through was quite something that I was quite concerned about for a long time. On a personal note, around that time, my mother passed away from liver cancer, and had this tracker existed then, that might have been possibly avoidable, but we never know these things. So obviously it's a passionate crusade of mine. I came into this practice 8 years ago, and luckily for me, the partners are very forward thinking and here in this capacity. And when this tracker pilot came up, I took our practice, at the time she was our reception manager, and I took her to the training, and we just thought it was really straightforward, it was simple. There were some challenges for us in terms of implementation. There were things we didn't really foresight, such as the amount of administrative kind of outlay it would require, but it was something I was really passionate about, and with a lot of kind of gentle pressure, we managed to try and get the resourcing to go behind it. We piloted it in our practice. It did really great things for the patients. There were some near misses that we could demonstrate that were avoided because of the safety net. So in terms of case studies, there were some really, really interesting ones. And certainly when CQC came to talk to us as a QI initiative, they were really quite pleased with how this safety netted our patients. Over the course of a few months, or a few years, should I say, we started to put more and more resourcing behind it. I got involved with training some of the GPs around in the toolkit, certainly in our PCN, got everybody on board with it. And now it's such an intrinsic part of our practice, especially with COVID. We've allocated a care coordinator's role. Part of the care coordinator's role, with our administrators, we've heavy lifted it. We've started to use it in ways other than just cancer. So I'm sure there'll be plenty of stories about that, but we are real champions of it here.
That's really helpful, Rasha, really great. Thank you for sharing the kind of the emotional connect with your mother as well. I mean, that sounds really difficult. One of the things I pulled out from what you said was CQC, so that's really interesting because that comes up a lot. In fact, people approach me because CQC have asked them to do that, so that's really interesting. And one thing I think that viewers might be interested in is actually, as part of that process of implementing, you had created your RAG rating system, which I think we'll show after we speak, but I think that's quite helpful because actually what this conversation is about is how can other people start it, optimize it, push it onto scale. And so this is where we bring in Tanya, because actually, Tanya, what you've done at the PCN level is such an interesting story. So why don't you start on your kind of journey of how that all began and how you achieved what you've achieved with that?
Well, definitely would say it's still a work in progress, so I don't want to like all of the things these things are. So we started very much at like I said, about 3 or 4 years ago, we managed to get some money to incentivize quality improvement around cancer. So we asked GP practices across Tower Hamlets to review their processes around safety netting, not specifically to implement this tool, but to have a look at what were they doing, what was working well and what wasn't. And then within that pack, we put forward some information, Macmillan-based, UK-based, around what is safety netting and the importance of it. And also we plugged the EMIS safety netting tool. It wasn't something that we mitigated had to be done by each practice, but it was something that we knew was available and we wanted to support practices doing it. So that was kind of like a sort of almost like a soft launch back a few years ago. And off the back of that, a lot of practices is pricked up, a bit like what Rash was saying, showed an interest in terms of how can we do things better. The realization was that a lot of practices had very much paper-based systems. So really what gave us a big angle, I suppose, and another way of keeping this on the radar, because my analogy is always like these books on a bookshelf, you put too many books on the bookshelf and it breaks, and when you slot one on the end, something drops off, and we wanted to keep cancer on the bookshelf. Was the kind of the national DES on early diagnosis was really another vehicle for us to say, you remember that quality improvement work, what are you doing? So within our network, we're quite a small network, so about 33 to 34,000 patients. Everyone was very much on board, and we looked at centralising some of the admin role for this. So one of the biggest feedbacks we had from practices was, yeah, Tanya, sounds great, but actually sustainability, especially through COVID with workforce issues. Who's going to run the search? Who's going to check the tasks are being cleared? Who's got oversight? So one of the things we did as a network is we looked at whether or not we could centralise some of that system of checking, not necessarily the doing, that's stage 2, but actually making sure that each practice had it in place, that it was updated, that they were primed and educated on use of it. So standardising the kind of the quality of the use of it. We also suggested that everyone started quite small, and we suggested that we all start with, like, for instance, the 2 weight forms and fit testing, because we were doing a lot of that through COVID as well. And then what happens is within the network, we have a centralised recaller who runs the searches on behalf of the practices and has a look and says, guys, actually doesn't look like they're being cleared. It's almost like a safety netting system, if you see what I mean. And making that outside of the practice to sort of nudge practices into ensuring that they're looking at the list, but also troubleshooting, you know, is it because your receptionist is down or your admin person's off with COVID, whatever, all those things that you know you can't predict but happen on a daily basis in primary care. So we have been we've got, like I said, a structure in Tower Hamlets where we've also got a cancer meeting every year, and we've been sharing the examples of that with other networks. And not through any incentivization, but through just what good practice looks like, but also, I guess, reviewing a bit like Rasha, we've been reviewing with each network the near misses and how the cancer tool has helped us capture some of those patients. So the case-based discussions and the learning from our network, we're sharing with the other networks to promote it really, and hope that they adopt it. But one of the biggest stumbling blocks for us as a group was definitely the admin side of it, and ensuring that there was a system of cover for that went slightly beyond the practice, especially if you're a small practice. Those are some of the highlight points really, Afsana. I don't know if you want me to stop there and you can.
Yeah, do you know what, Tanya, that's really helpful. And I suppose what might be key for the audience really, or people listening to this, is about what do we need to do if you were going to pull out some specifics to do this at scale? So I heard you say actually carve out a central admin. So someone has to have that role. It has to be in their job specs, has to be kind of related to that. So that's probably one. Is that right?
Yeah, I would split the admin up into two things actually. I would split up surveillance and safety netting of system admin versus the actual cold calling of patients. So a lot of the practices wanted to retain the calling because a lot of the practices obviously who knew the patients, knew they'd gone down the to-be rate route, it felt more appropriate for some of them to be called. So quite a few practices, can we keep the calling if possible, but we'll let you know if we're struggling and we can give it to you. One of the other networks in Tower Hamlets is putting the calling central, all of it. But they've done other processes as a network where they've done centralized recall anyway. So this is just slotted in.
And that's really helpful, isn't it? Because I suppose as we're all moving to that world of kind of looking at primary care at scale and sharing back office admin function, this might not be a whole new thing in itself, mightn't it?
No.
Just, I suppose one other thing that I picked up from your brief was that you mentioned starting small, and I think that's really important, isn't it? Where you choose page 1 and then you add in page 2 and then page 3. So I think if people were listening to that, that's probably the way to go forward with this, and it kind of mitigates against some of the risks, isn't it? Because if you go full on, then you've got a lot more to, if something goes wrong, then you've got a lot more to kind of back cover. So that's really helpful, and I hope that sort of gives people a lot more kind of practical tips on what you need to do. If I can bring in Jen now, in terms of, so Jen, you've done something really interesting in terms of supporting this, to support the national kind of contractual aspects of it. So why don't you tell us a little bit more about that?
Okay, no problem. So I mean, I think across Islington, so I've essentially tried to reduce the work of GPs by synthesizing a lot of the information and the amalgamating the ask of the QOF work in addition to the DES work. And then work to sort of bring practices, sort of give them resources that will help them to meet the things that are expected of them, really, and then bring everyone together and coordinate the PCN level meetings. And one of the nice things about being sort of in a coordinating role with all of this is that you have oversight of everyone's sort of action plans for this work, and then you're able to network certain surgeries together and help practices to share resources that might be useful when they're doing similar projects. And so that's probably been one of the biggest wins of this sort of work. But I think sort of with my quality improvement hat on, what was immediately obvious from the beginning was that one of the onerous tasks about this was having a good understanding of measurement. So if you have people who are implementing and doing all this work to implement use of the template, how are you actually going to monitor it? And then putting that back to practices and saying, well, you have to monitor it, was just another ask above and on top of what they were already doing. And so what we felt very strongly about is we want to take that away from practices. And so we were lucky in the sense of the way the Federation set up with practices that we already had data sharing agreements. So we were able to just expand those. And then with the help of IT analysts at the Federation, we essentially created our own dashboard for early cancer diagnosis work within Islington. I worked with Afsana, and then with Afsana's help, we worked with sort of EMIS nationally to change slightly the coding that was used on the templates to allow us to pick up when the safety netting template was actually being used. And even just that small marker allowed us to then drill down to not only how often it's being used, but generate a dashboard that could show us sort of what practices were using it, how they were using it, and how they were progressing over time as they implemented these different change projects. And from a sort of, again, having oversight meant that you could really understand where practices were the sort of early adopters, and they were literally flying with the project, and then that helped me to bring them back to the PCN level meetings and actually share their experiences of what they'd done and what worked well for them and how they'd benefited, as well as what they'd struggled with, and that helped us to share learning, and that's very much an ask of part of the ECD level work. And then equally on the other side, it gave a very clear view of what practices, where their expectations might have been to implement, but actually where they were practically struggling. And that might be because they didn't have admin support in practice and it just wasn't feasible, this ask. But could we support also in a different way? So, could we ask some people who've worked within admin teams to actually come and speak to practice's admin team to show them and demonstrate at their level what they were doing, and it felt very much getting the right person to the right team at the right time, I suppose, and then creating a sort of troubleshooting aspect to this, which is, because you've got to understand that, you implement something, but you'll always have questions as you go along, and knowing how to answer those questions. And so it's been good to sort of be in this role and be able to help facilitate that for practices and make them feel like they they had somewhere to go when they had a problem and they just didn't sort of come to a standstill.
That's really helpful, Jen. And I think the take home is that actually there is a role for federations within the sort of safety netting realm, isn't there? And that actually at scale, it doesn't compromise the functionalities of this tool. One of the things, I don't know, Catherine, if you can bring the PowerPoint back up, is, so Jen, would you say that the work that you've been doing and having the dashboard to be able to visualize, did that increase the uptake of people using it? Did it, what would you say? Did your work, was it fruitful?
So it has been really, really fruitful. So we were able to demonstrate that by the end of the first year of the work, which was really incredible amidst COVID and everything, that we were able to show that there was an increase in the template use by about a third within the first 12 months. And then the actual, the usage, so the rate of use, so how many times practices were using it per week, for the ones that had implemented it across that year, actually increased by 40%. So, and it's still moving. So, they're very much, what's lovely about it is practices can start with a really small change. Maybe it's just the 2-week waits, as you say, and then they can build on their ambitions and then gradually see the benefit of that and watch their numbers. I think that's another really lovely thing to be able to say, well, look, we're going to collect this data and look at what your hard work is kind of is showing, and that's good to help practices encourage as well.
Brilliant. Okay, so Catherine, I think we're on the wrong slides. We want to show the ones where all of Jen's work around kind of practices picking up and all those read codes increasing. And then Anthony, can I bring you in? Now you've got a really interesting position, because with your kind of London-wide and national position that you're in, you obviously hear about feedback from like much wider than London. So it'd be good if you've got any reflections and maybe some pros and some cons of what you've had in your time.
Yeah, absolutely. I guess one reflection is around, and I guess why a lot of the work came into play and other safety netting processes and tools, which we'll probably talk about, is because Macmillan led on a lot of significant event analysis and learning event analysis work for many years. And there were some, individuals, but also some big projects done across geographical regions. And, it's probably not an exaggeration to say that probably 90+% of the time, at least one of the learning points from all the SEAs was something around safety netting. And so there was just a really, really clear message that there was a need for something more robust than just primary care education around safety netting. Now, obviously that, we're talking about very much about systems now, and none of that is negating the importance of the education as well, because, we all know that first element of safety netting should happen in the room or over the phone or over the video consultation with the patient, with the backup of these robust IT systems, because we know that patients don't always necessarily hear what we think we're saying to them or take heed about explicit messages, etc. But they go hand in hand. We should never rely on these and then kind of ignore those really qualitative elements of the safety netting conversation. So, and those things came out loud and clear from the SEAs. You can't really one without the other isn't effective. So I think that's a really clear message. And then certainly nationally, you know, yours was certainly the first, if not one of the first, if not the first of these kind of tools to be developed, Afsana. And we would hear repeatedly, you know, when we talked about it at events, etc., or people would hear about it through our communications at Macmillan, we would get people messaging us all the time, initially to say, how do we get it in our system? Because initially, obviously, it wasn't available nationally through EMIS, which is why we supported the work there to try and, you know, because if every practice or PCN was having to go through that download process, you know that it was just such a rate limiting factor on spreading the tool and the benefits of the tool. So we would hear them, all those messages initially. So it's great that it was made national, but also now repeatedly the message we hear is, and I get emails weekly saying, well, hang on, when is it available in IMPS Vision, or more often than not, when is it available in System 1? Obviously there are some there's certainly similar functionality within the different systems, and we know that one of our great colleagues, Pavan Mendev, has done a lot of work around trying to get a similar function, a similar tool within System 1, and it's not quite got the spread that yours has got at the moment, but hopefully his work can be supported so that then people within System 1 can have access to a similar tool with all the similar benefits. And then again, I guess we often hear people who are using adjunct IT systems, and you know, I don't know whether it's to talk about these now or later, but people who are using Ardens or DXS, very much they move almost wholeheartedly over to the function of Ardens rather than the basic functions of EMIS itself, and therefore Ardens and DXS and other companies like See the Science have worked hard to make e-safety netting tools within their systems as well. Now, I'm not as familiar with how they work as I am with your tool, but I guess one of those messages is we want everybody to have access, either at practice, but ideally at a bigger footprint level, to a robust IT-based safety netting tool that then everybody can be encouraged to use, because we also know these tools are only as good as they are used. So it's really important that we get everybody within a practice or everybody within a PCN using that, so that there's equity of access there. And so it doesn't really matter what tool it is. Obviously, you've worked really hard to make yours really easy to use and consider lots of other things other than just 2-week rule referrals, which for me are some of the almost better elements of it, because those are certainly elements we weren't perhaps doing before. But it's about making sure people are aware of all the different IT tools and maybe the benefits and limitations of some of them, so that everybody's using one that really works for them and the kind of footprint. Because I guess another thing I might say about admin, everybody's mentioned admin, which is great. It's a really loud, clear message, isn't it? And for me in our practice, it wasn't about getting admin support, it was about giving it to admin and letting them completely own the tool, because that was definitely what, you know, accelerated it going forward. And they're the ones that bug us if we're not using it, you know, particularly around, say, Fit recently. You know, they've been really on our backs because we're using it for other things and we haven't necessarily been using it across the practice for all our fit tests. So we have people who are kind of overseeing how successful it can be, and for me that's been way more successful than, say, one of us clinicians owning it, for our practice at least.
That's brilliant, Anthony. And, you know, you brought a whole load of themes up there, which is absolutely fine. Let's just bring some connectivity. So some of the things you talked about around kind of, you know, this is one way of doing safety netting, but actually let's not forget the patient interface. And actually, George is going to talk to us a lot about that when she introduces herself and talks about kind of the vision for the future. So that's the first thing. And then really, Anthony, you've really launched into the next bit of the conversation, which is helpful because we probably need to talk less about it, and that is about supporting practices on those choices that they make about the other tools. But before we move on to that bit formally, can I just hear Jen, Tanya, Rasha, one word from e-safety netting, just one word. What would you tell practices? What thing? What keyword? And then you're done. So Jen, you go first. You're the top. Go.
I would say worthwhile.
Okay, Tanya.
I would say try.
Rasha.
I would say essential. We can't live without it.
Okay, really kind of diverse words there, aren't there? That's so helpful, everybody. Thank you. And I hope our viewers sort of taken some of these key messages away with them. I'm happy if you want to go off camera, if you want to stay, you don't want to stay, up to you. But I think the rest of the conversation is going to be equally as interesting. So highly recommend you stay. Anthony, shall we move on to, so is it possible, Catherine? I think you might be struggling with the slides, but we really want to focus on slide 21 now, which is the conversation that Anthony started around other e-safety netting tools. Oh yes, so this is the slide that I was referring to about the dashboard, and these are all within the case studies that we published on our website, and Catherine, I believe, is putting the links in, so you can have a look at that. And this is obviously a while ago, and as you've heard from Jen, you know, this has been increasing all the time with all the hard work that she's been putting in to support the practices on that. So if we keep moving forward, so we know that actually there are lots of tools out there, and these digital, I'm going to call them digital tools. There are lots of digital tools, and they do a lot of things. And some of those things might be what we consider safety netting. And you've heard us talk about Ardens, you've heard of DSX, See the Signs, and people even talk about Accurix SMS. So a whole host of tools that do some bits of safety netting. And I think I get asked a lot, and I know Anthony, you do, about what do you recommend, Afsana? What would you choose? And I think it's not really my place to tell people what to do, but what they need to be is informed about the product and what their needs are, and see if that product matches with their needs, really. And so really it's about being, for me as a sort of the safety netting goddess, it's about the robustness of electronic call, and George is laughing at me, call and recall, and recommending that practices, whatever system they deploy or employ, is that they are have the appropriate training that delivers that system of choice, because it's not just the IT alone, is it? And then the other major factor is that sustainability piece. So remember, e-safety netting within EMIS Web is obviously free because it's part of your electronic health care record system, but other systems might not be so. If we move to the next slide, and now I'm not going to read these all out, and I know we're going to share these slides, but these are sort of some thoughts that came to my mind when kind of coming down to the specifics of what are those things that you should be looking at, and really broken down to functional and enabling processes. And at this point, I think I'm going to ask Anthony if you've got any kind of, I suppose, additional thoughts or reflections or advice for practices on when they're making these choices.
I think I would definitely go back to your point about sustainability, Afsana. I think it's key. We know that we're not generally the most we're not generally as quick in primary care at adopting new systems. It can often take us a while. It can be a really slow process, and there are various reasons for that, especially because we're even as teams within one practice, so a lot of us are part-time, we don't see each other all the time, so I think we often move slow, and so it can take a while to really adopt a system practice-wide, PCN-wide, and we know that things change a lot in primary care. One thing we've all probably had, apart from maybe we've changed over from one IT system to another, which has happened to some people, but a lot of us have now been working with the same IT system for a long time. But in that period of time, we've had other things come and go. So certainly I know in my ICS, we've got 2 adjuncts at the moment that are both being funded just till a certain period of time next year, and we don't know what's coming after that. There are people making complex decisions that are about way more than cancer safety netting, and decisions that perhaps involve a lot of money as well. And so it's really hard to really go wholeheartedly try and get a real buy-in on a system if then in 6 months, 12 months time, it could just be decommissioned, and then you're starting from scratch again. And as GPs, we kind of hate that, don't we? And for really good reasons, and we see it not infrequently. And I think that's the problem with any extra service that's commissioned, which essentially is all these other safety netting tools. I think they've all got fantastic benefits. And of course, there are some areas that have made a push around one of these other tools and have had, we've heard they've had success. The problem is, if for whatever reason in, like I said, 6-12 months time, that service is decommissioned, probably for separate reasons other than safety netting, then you're starting from scratch. But with the EMIS tool, unless people are going to move over to a whole other IT system, which I think is perhaps a lot less likely when you're on EMIS Web anyway, then you have got a consistent tool, and it's not just the clinicians, it's everybody in the practice that is used to using that tool, and systems you've got set up, and perhaps searches you've already got planned. So I think that's probably, for me, one of the strongest reasons to go with the tool that's in your fundamental IT system, because also, for me, it does everything that these other tools do as well. It's not like you're compromising by going with that tool, but you've got a confidence that it's not going away anywhere soon, and that somebody's going to update it as well, which is really important as well. I'm sure all the other tools, have those update processes as well, but to me, that would be the fundamental one, Afsana.
That's really helpful to get your perspective on that. So now I think this is the time to move on to the next piece. So if we move to the next slide, really, this is really odd, isn't it? Like, I'm asking you, what is e-safety netting? And actually, I thought we all knew what e-safety netting was, or do we? So it gives me great pleasure to introduce Georgia Black, who is not a pop star, but something much better. So why don't you unmute? So we've been thinking, giving a lot of thought to this kind of almost philosophical kind of question around e-safety netting, what it is, what does it mean? And that's led us to this next piece of work that Georgia's going to talk to. So I'm going to be quiet and really let you run the show here and obviously introduce yourself. Thank you, Georgia.
Sure. I'm also going to suggest that I present from slides from my end, because there are a few animations and things, so I'm not sure if it's going to present a problem. Tell me if this doesn't work. OK. So thanks so much, Afsana. I really wish I was a pop star. I'm sure I had dreams of that at some point in my teens. I'm an academic at UCL, and I'm really interested in early diagnosis of cancer. I've become particularly sort of interested, or nay, obsessed with safety netting in the last 3 or 4 years. And that's how I met Afsana, because we have so many shared interests. And my starting point for thinking about safety netting was really what the patient understands when they're being given safety netting advice, or they're having particularly kind of vague or non-specific symptoms managed in primary care. And it's a job of someone like me to consider what kind of things can go wrong and can therefore compromise, your attempts to diagnose cancer as early as you can. And I know how difficult that job is. And I'm not a GP. I have a sort of psychology background. But I'm by no means saying that I think it's an easy job. And more recently, we've become interested in e-safety netting because there's a recognition within the sort of academic world that, and we've sort of taken its cue from other areas of patient safety research, that really the system needs to be capable of supporting the individual. If the GP's job is really hard, then something in the system they work in needs to be helping them, reducing burden, spotting risks, helping mitigate those kind of inevitable human fallible moments that everyone goes through. As several people today have said, there's really a lot of tools out there that are designed to support GPs in safety netting practices, and they do lots of different things. They can help you with sort of making decisions about whether or not to refer, or kind of give you risk calculation scores about the likelihood of the patient in front of you having cancer. And they can help you with things like tracking and monitoring, which you've seen. And they can help mitigate sort of process errors that can happen. So they can kind of tell you if a certain delay has elapsed. It can track, obviously, DNAs, non-attendance. But it can also help you review practice at a kind of practice level, or performance at a practice level, or even at a PCN level, which can be quite helpful for sort of benchmarking and improvement. And a lot of the GPs we've spoken to today kind of talked about that. So at the moment, in collaboration with the North East London Cancer Alliance, I'm conducting an evaluation of another of the e-safety netting tools, See the Signs. Of course, there are a lot of parallels and kind of interesting similarities between that and the EMIS tools. And with Afsana and the sort of Oxford primary care academic team, we're developing a sort of framework to try and understand, what would an ideal e-safety netting tool do, or what are the kind of principles that we want them all to have so that they're working optimally. So I'm going to talk a little bit about both those things now, just to give you a flavour of what that might look like. So I want to think then about how these, but it's the outcome that's important. It's not the tool itself, but it's how it actually helps you and helps your patients. So let's think a little bit. It's sort of identifying and mitigating errors. And I wanted to give you an idea of some of the sort of errors that might be relevant when we're thinking about safety netting. So things like, you know, you decide not to investigate a red flag symptom because momentarily, you know, you forgot it was a red flag symptom, or, you know, so one of the rather unusual ones, you haven't seen a patient with that symptom for a long time. And so the system might be able to kind of alert you to the fact that something's been missed. That'd be very helpful. Or it could be that the patient doesn't reconsult with you within the time frame that you'd agreed. So you're sort of tracking a vague symptom and you want them to come back in 2 or 3 weeks, but then they don't call. It can alert you to the fact that that might have happened. So it's sort of spotting errors that might incrementally add up to a kind of longer delay in diagnosing cancer. And really a good tool would also mitigate and reduce the burden on you for doing that. And we've heard today, I think it was Tanya saying about how you kind of need a team around you to safety net the safety netting. So how, you know, these tools shouldn't be creating an extra burden for GP and their colleagues. They should be reducing it to make it easier to do your job, ideally. And by doing sort of one of the key ways of doing that is sharing the responsibility for tracking all those things in a way that's seamless, not in a way that creates lots of extra systems and spreadsheets and tasks and all those things that I know slow down your working lives. So in trying to set standards, we're trying to give guidance about tool development, so to the software developers, obviously to researchers like myself, and to practices that are doing local quality improvement and evaluation. Because there's a huge variation in the functions within the different e-safety netting tools, which is kind of confusing. So what I have noticed in my evaluation work is that quite a lot of GP practices install multiple e-safety netting tools and use them quite variably, and use one of them to do referrals and another one to do decision support, and you kind of ne'er the twain shall meet, and it's not very linked together. And it's also the case that sometimes different GPs within the practice have their sort of favourite tool and they're using them all differently. So again, that kind of that reduces the kind of benefit of installing that system. So sometimes the e-safety netting tools, they don't seem to be related to specific errors that they're trying to prevent. And that's one of the things that's really key for me, is how is it mitigating or kind of reversing, spotting an error that might sort of create a diagnostic problem. So currently, I'm going to give you this framework in a second, but there's no tools that do all the criteria in the framework. So this, you know, this is a kind of work for the future. So here are my principles. You tell me what you think of them later on. So a key thing for me is that all patients that are registered can potentially be e-safety netted. It shouldn't just be patients where you've already decided that they might have cancer. It should be doing alerts and pings and mitigation for patients who you suspect of having other diagnoses too. Otherwise, it's too cancer specific and it risks missing those rarer cases. It should also be for all clinicians. So if it's built into a system, if it's sort of switched on all the time, all clinicians get the benefit of it, rather than, you know, oh, it's just for the trainees or it's just for the permanent staff, or, you know, locums, everyone should be kind of constantly immersed in an e-safety netting system. It should be automatic where possible, and that's so that it limits the burden on you and the sort of potential for fatigue, cognitive bias, you know, being a human being. So things like sort of automatic autofill, automatic alerts, those things are, you know, where they're judged right. I know it's annoying to get lots of pop-ups and stuff, but where they've been kind of calibrated to work well for you, that really saves you a lot of burden and time. It should support diagnostic processes both pre, during and post consultation. So it should support you to kind of be ready for consultation by flagging up, I don't know, bits of missing information in the patient's medical record, for example. It should be easy to load and kind of use within the time frame of the consultation. And of course, it has all these sort of tracking and dashboarding functions post consultation. It should be able to monitor and auto detect and alert you to diagnostic process errors. So where things have been missed, where things have gone wrong, it should be constantly monitoring for them. It shouldn't require you, for example, to put the patient on a watch list in order to detect that there's been a delay. It should just happen automatically. The processes should be really simple. So it should make it easier for you to access and sort of transfer complex information. So if the patient's got a really complex medical history, you shouldn't have to be manually tapping that into a referral form, for example. So you want a really high quality transfer of information across from the patient record into, you know, communication with the specialist or anyone else who needs to know. The tool should spread responsibility and roles within primary care. So there are probably things that you as GPs end up doing, but they could be being done by someone else in the practice. It could be being done by an administrator, or it should be easy for the administrator's tasks and functions to transfer easily over to what you need to do, and sort of have a sort of impact on the practice as a whole. Of course, these tools should support your senior leadership and your clinical leads, your cancer leads locally, and sort of other levels, so PCN, CCG levels. They should be supported to kind of spot and optimize safety strategies, and you know, these tools should be part of a kind of regular quality improvement program. And what would be really ideal is if there was some way for patients to interact and feedback with those systems. So I know that there are some tools where patients can kind of enter information. I know that Accurix can kind of put information from the patient automatically back in the patient record. But it'd be great if patients could be invited where appropriate, you know, where that's possible for them to sort of use and to validate and improve the quality of safety netting tools. So I'm sure you all will have some thoughts about these. I'd love to hear them. I'm sure Afsana would too. So finally, we will be sharing this framework. We're looking to publish it, and I'm sure Afsana will sort of cascade it around all the relevant channels. And in a few months, the evaluation of See the Signs that I'm doing will be in the public domain through NEL. All right, thanks very much. I hope I've left you 1 minute for questions. Sorry.
That's fabulous, Georgia. Thank you so much. So, you know, thoughts really in that last minute from the panel, if we can, because this is the first time we're really talking about the framework, isn't it? You know, simple ask, easy ask, achievable. So, you know, I mean, so I suppose, you know, why don't we like use the last minute for people just to shout out a few thoughts, and then, you know, we can wrap up if that's okay. Who's rearing to go? Rasha, you wanting to?
Yeah, I can quickly go. Just to say that really useful tips on how to scale bigger. I think the idea that the framework that you were discussing, actually, Georgia, really fascinates me. Like I said, the patient safety thing is quite big in my radar, but something we found really useful is we layered on the layers, and it was the RAG rating that Afsana might allude to it in another talk, but we started to embed it into our GP handbook. So every locum, every trainee, every doctor that comes in, there is a 4-step process to any patient with a high risk or even a possible risk of cancer now. There are 4 steps they have to do, and it's really clear process mapped, and everybody aligns to it. And the tracker is dedicated a whole day by one of our care coordinators and administrators who back them, and they go through every patient, and it's fed back to the doctors in tasks in a way that actually the doctors fed back how they wanted it, that they wanted to know about those patients. And so we designed it around that. So just in terms of RAG rating, we created a list of things that they must never put on the tracker, and stuff that they can put on the tracker. So things like rapid access chest pain clinic can go on there, peds urgent care referrals go on there now. So like you were saying, Georgia, it's not just for cancer, it's now in our practice, it's for everything, even the high risk weight loss patients, you know. So it's a heavy duty machine, but we use it and we rely on it super heavily. So I recommend it.
Brilliant. So I'm conscious 1 minute past 2. So I think if anyone does want to feedback, we can always use Teams to put our messages in there, or you can email us and we can make our emails available. So it's been a real pleasure. Thank you, everybody. Thank you for squeezing this into your busy schedules. I really appreciate it. Thank you so much.
Thanks so much.
Thank you very much. Thanks so much, everybody.
Bye.